Now look at this question here. A 30-year-old female presented with hypertension, chest pain and cramping of legs. So young female presenting with hypertension, something strange, chest pain, cramping of legs is a clue. Chest X-ray was done and is shown here. What is the most likely cause of hypertension in this patient? So all the options are related to the cardiovascular system. Remember, this is actually a spotter and the beauty here lies in the details. I'll not tell you what the diagnosis is at this point because we are going to discuss this condition. But just see the contour of the aorta there is what is giving you an actual clue. There is a small narrowing along the aorta. I think this is a clue enough. So this is a narrowing along the aorta. What it is, we'll discuss in detail as we go ahead. Yes. A child presents with cyanosis, so cyanotic congenital heart disease. Chest X-ray is done, reveals this finding, a very peculiar shape of the heart, right, with the heart apex which is turned upwards, a very typical boot-shaped heart, core and sabot appearance seen in tetology of Fallot. This is one of the absolute favorites of your examiners. Multiple times a question has been asked on congenital heart disease and this appearance. We'll discuss all the various appearances as well. Okay, now a 12-year-old child presented with fever, cyanosis and fatigue. His chest X-ray is shown here. What is the most likely diagnosis? See, another similar question based on congenital heart diseases. See, very peculiar shape, two round opacities, so figure of 8 or a snowman's heart seen in a specific type of congenital heart disease. We'll discuss it as we go ahead. So remember, this topic of congenital heart disease is basically a treasure trove for various named signs and appearances in radiology. A treasure trove of named signs and appearances. Multiple named signs and appearances have been there. In the previous era, when a printed question paper booklet and an OMR sheet type entrance exam was conducted, these were factual MCQs. Now with the changing exam pattern and which seems to be more and more getting established, there are image-based questions which you will be asked. Various image-based questions have been asked on these particular topics and we'll discuss most of the imaging appearances. Right. What we will focus on here in today's discussion in radiology, congenital heart disease infection, discussion is basically the imaging signs. So I'm going to focus more on the imaging manifestations and signs for diagnosis. Though for diagnosis, to make a correct diagnosis, the clinical perspective is also important. This clinical perspective you will be studying in detail along with the management part in your pediatric videos. So let us focus on the radiology of congenital heart diseases. Let us start with transposition of great arteries. Now the appearances in transposition of great arteries, let us compare it with normal. So see here, can you see the difference? Normally in the pediatric age group, the mediastinum, superior mediastinum is usually considered to be wide. Why? Because of the prominent thymus gland, right? Then the heart, right here, looks more or less normal in shape. Look at this particular radiograph here. What do you see? We see that in this particular radiograph, the heart is more or less oval in shape or ovoid in shape, like an egg which is lying on one of its sides or egg lying on a string. So what is this called as? This is called as egg on a side or egg on a string appearance. Egg on a side or an egg on a string appearance seen in transposition of great arteries. Another very important difference is that here we have seen in normally how the mediastinum is wide because of the prominent thymus. Here, can you see the mediastinum is extremely narrow. So narrow superior mediastinum is another feature. Why is it so? It is because in TGA, transposition of great arteries, the origin of the great arteries is flipped. So normally the great arteries lie side by side. That also contributes to the mediastinal shadow. But here in TGA, because the origin of the arteries is abnormal, instead of lying side by side like this, the arteries lie one behind the other. That creates a narrowed mediastinum. Also because of the cyanosis, there is stress and this stress causes thymic atrophy. And therefore this mediastinal narrowing is seen. Right, this narrowing of mediastinum is considered to be one of the most reliable or most consistent finding of transposition of great arteries, along with the egg on string and egg on side appearances. Now come to a condition called total anomalous pulmonary venous return or pulmonary venous circulation. Now there could be various types. What is this? Just look at the name. Total anomalous pulmonary venous return. So what is the normal pulmonary venous return? Normally the pulmonary veins open into what chamber? They should open into the left atrium. When they do not open into the left atrium, it is called anomalous pulmonary venous return. When is it called total and when is it called partial? When all the four pulmonary veins drain in an anomalous manner at an abnormal site other than LA, it is called total anomalous pulmonary venous return. What is partial? We'll see that when we go ahead. So depending upon where they drain, it could be various types. The most common type of TAPVC or TAPVR is supracardiac type, in which, see, behind the heart, the pulmonary veins, they join together to form a common channel. They form an anomalous vein. They form an anomalous vein that rises up, joins the innominate vein, and then drains into the SVC. Through the SVC, they are draining into the RA. So that is anomalous venous return. This is called supracardiac. This is the most common type. Now, if they drain within the heart itself, it is called cardiac. So they drain usually within the coronary sinus in the cardiac type. So there is a dilatation of coronary sinus. They can drain in an infracardiac manner when an anomalous vein is formed. But in the first example, it went up, joined the innominate vein. The anomalous vein goes down and it joins the portal vein or the IVC, either one of them. Or it could be mixed. Some veins join the innominate vein, some veins, enter directly into the RA. So that is mixed. The most common type of TAPVC is the first or supracardiac type. And it is this supracardiac type. See, what is supracardiac type? We have seen that these veins form a anomalous vein. And this anomalous vein goes up, drains into the innominate vein, right? And then it comes down. So this, because of this particular, structure of venous channels, right, they create this upper round shadow or upper round opacity, that is the head of the snowman, and the normal heart forms the body of the snowman. So this is called as what? This appearance is what is called as the snowman's appearance, snowman's heart, or figure of 8 heart, snowman's heart or figure of 8 heart. So this is what is the appearance seen in total anomalous pulmonary venous return. Now we have discussed what is TAPVR, total anomalous return. What could be partial? What could be partial is that when 3 pulmonary veins drain normally into the LA, but 1 pulmonary vein drains in an anomalous manner. So this pulmonary vein is given a name. It is called scimitar vein. Why? We'll discuss this. It goes down and drains most commonly in the IVC, right? So this is an anomalous vein which travels down and it drains most commonly into the IVC. It would also drain into the hepatic veins or the portal vein. Now it creates certain peculiar appearances. This is associated with a syndrome which is called scimitar syndrome or hypogenetic lung syndrome. Scimitar, meaning of scimitar, is a Turkish sword. So see, look at this X-ray image. This is how a Turkish sword looks like. And there is a vein, an anomalous vein, which passes as a linear channel below the diaphragm and drains into the IVC, right? And this is what takes the shape like that of a Turkish sword. So this is called as the Turkish sword sign or scimitar sign. So this appearance is also called scimitar sign. Now, hypogenetic lung syndrome or scimitar syndrome consists of certain components. What does it consist of? It consists of right lung hypoplasia. Right lung hypoplasia with a resultant dextroposition of the heart. Dextroposition of the heart. Right lung hypoplasia with dextroposition of the heart. There is also hypoplasia of right pulmonary artery. Right pulmonary artery hypoplasia. Right? Because the right pulmonary artery is hypoplastic. Right? Who will supply the right lower lobe? So there is an anomalous supply. Anomalous blood supply to the right lower lobe from what? From the aorta. And then there is an anomalous vein which is called as the scimitar vein, and we have already discussed, we already seen this vein. It goes down and drains into the IVC. See here, this is a reconstructed CT image in which this anomalous vein is seen going down and draining into the IVC. That is how the blood is going to go into the RA. So this is anomalous return, but only one vein is abnormal, so it is called partial anomalous pulmonary venous return. This is scimitar syndrome or hypogenetic lung syndrome. Yes. So look at this question. True about scimitar sign on an X-ray. Is it named so because it looks like a Turkish sword? Yes, we have seen this. Seen in scimitar syndrome or hypogenetic lung syndrome is correct. Occurs due to partial anomalous pulmonary venous drainage of the right lower lobe is also correct. Is it seen in cardiac TB? No, absolutely not. Seen along the right heart border? Yes, the Turkish sword or the scimitar vein goes down along the right heart border. So the answer in this case, because this was a PGI pattern question, answer is A, B, C and E. That was the correct answer in this particular question. Yes. Now see, a very classical appearance of the heart or a very classical shape of the heart that you can see here is the apex being turned upwards. This is called as your boot-shaped heart. Boot-shaped heart or core and sabo heart, right? Now, why is there core and sabo appearance or boot-shaped heart? See, what are the four components of tetralogy of Fallot? Pulmonary stenosis, membranous VSD, overriding aorta and RVH. Out of these 1, 2, 3, 4, can you tell me which one is predominantly responsible for boot-shaped configuration of the heart? It is RVH. Why is it so? It is so because, see, this is the normal shape of the cardiac apex like this. Cardiac apex lies here normally. Now, whenever there is cardiomegaly in adults, the commonest cause of cardiomegaly in adults is LVH, left ventricular hypertrophy, secondary to systemic hypertension. Whenever there is LVH, it causes cardiomegaly. But how does it cause cardiomegaly? It causes a shift in the cardiac apex. It causes a shift in the cardiac apex that is downwards and outwards in LVH like this. But if there is RVH, where is right ventricle located? Right ventricle is located anteriorly here, isn't it? We have seen the various chamber locations. When a right ventricle hypertrophy is in top, it causes a shift in the cardiac apex. Where? In what direction? It shifts upwards and laterally like this. So if you take this as your cardiac apex now, see, look at this particular shape of the heart. This is your boot-shaped configuration of the heart because the cardiac apex shifts upwards and laterally. Another very important feature of tetralogy of Fallot is its associations. It is associated with right-sided aortic arch. In almost 30 to 40% of cases, there is a right-sided aortic arch. And look at this particular image here. If you watch carefully, the aortic arch is not seen on the left side, but see, this is the aortic arch which is going down. So it is this child which was also showing an association with a right-sided aortic arch. So this is what is the boot-shaped appearance or core and sabo appearance. Now, along with this, if you look at this now, this is the area of the heel of the shoe. So the heel of the wooden shoe is formed by what chamber? It is formed by the right ventricle, remember, right? So apex is upturned, so the heel of the shoe here, or the core and sabo appearance, wooden shoe, is actually formed by the right ventricle. That is another thing that could be asked. Now let us come to coarctation of aorta. Coarctation of aorta is what? It is basically a narrowing of the aorta. Coarctation means narrowing. Now, where is this narrowing most commonly seen? It is most commonly seen just distal to the subclavian artery, right? So we have the brachiocephalic, we have the left common carotid, left subclavian. So just distal to the left subclavian artery at the attachment of the ligamentum arteriosum, right? This is where the coarctation occurs. This is the most common site of coarctation of aorta. Now, what findings does it give rise to? Now, see what happens, because there is a narrowing here, the part of the body supplied by these branches proximal to the narrowing will receive very good blood supply, but the part which is distal to it will not receive good blood supply. So there will be a discrepancy in the blood pressure in the upper limbs and lower limbs. There will be cramping of the lower legs, right, because of vascular insufficiency, right? And there is development of collaterals because the body wants to supply the organs, supply it, that is the abdomen and the lower limb mainly. So what happens? Arteries arising from these arteries will form collaterals, and these collaterals will then try and supply blood to the lower part of the body. That is where we can clinch the diagnosis. Direct visualization. So, see the investigation of choice. So, chest X-ray can offer certain indirect signs, right? The investigation of choice usually for a diagnosis of coarctation of aorta is usually a CT angio or an MR angio. The gold standard is usually going to be a catheter angiography. Now, what do you see here in this particular radiograph? Now, in this particular radiograph, if I actually zoom up the mediastinal contour, see, you can see this typical constriction along the aortic margin. This is what is called as the figure of 3 appearance. The figure of 3 appearance or figure of 3 sign. This is because of the narrowing at the coarctation, little dilatation of the subclavian artery proximal to the coarctation, and dilatation or post-stenotic dilatation of the aorta below it. So this is what gives rise to the 3 appearance. Now, another sign which has been described in coarctation of aorta is called reverse 3 sign or reverse 3 appearance. So what happens? Because there is a 3-shaped, contour of the aorta, if I do an oblique projection barium swallow study, on barium swallow oblique images, what is going to happen? Can you imagine? Right, this 3 shape is going to create an extrinsic impression, right, on the esophagus. So if this is the aorta which is 3 shaped, what will happen? Right, this is the esophagus. There is going to be a reverse 3 shaped impression on the esophagus. So that is called reverse 3 sign, which is seen on the esophagus on a barium swallow study on an oblique image, right? Now, another peculiar feature of coarctation is the development of collateral channels. The rib notching that occurs because of development of collaterals, therefore rib notching, this is also called as Roessler's sign. This is also called Roessler's sign, right? Now, why do these collaterals happen? Because we have discussed the distal body is not getting good blood supply, and the body is trying to supply, blood to the distal part of the body by formation of these collateral channels arising from proximal parts. Now, which is the most important artery which takes place in the formation of these collateral channels? It is the internal thoracic artery or the internal mammary artery, which gives rise to the intercostal arteries, because the anterior intercostal arteries will eventually fuse with the posterior intercostal arteries, and that is how the blood will go into the distal aorta, right, distal thoracic aorta, descending thoracic aorta, and eventually into the lower part of the body. Now see, these are the intercostal arteries. Mainly, most probably this will give rise to collaterals usually from the 3rd to the 8th intercostal spaces. If you look at this particular image here, you can see along the ribs, you are able to see these notches along the inferior margins of the ribs. See, why? Because once these arteries take part in the formation of the collaterals, these arteries become enlarged, they become dilated, they become tortuous. So what happens? If this is the rib, inferior margin of the rib, along which there is the intercostal groove in which the intercostal artery is actually running, what happens? This enlarged intercostal artery, its pulsations are transmitted onto the inferior margin of the rib, which eventually undergoes remodeling, and that is where this notch is created. So this is inferior rib notching, right? Specifically, this is inferior rib notching or Roessler's sign seen because of collateral channels seen in coarctation of aorta. Now, a difficult type of question could be asked in your exam based on collaterals are seen where, whether they are bilaterally seen or unilaterally seen, that is seen in certain specific clinical situations. Now see, this is the aorta. You have the in brachiocephalic, you have the left common carotid and left subclavian. We discussed the most common site of coarctation is this, that is at the ductal insertion or just distal to the ductal insertion, distal to subclavian artery. So in this case, what will happen? In this case, see, from this subclavian artery, internal thoracic artery will arise, right? And this will what is give rise to collaterals on the right side. From this subclavian artery, again, the internal thoracic artery will arise. So this will give rise to collaterals on left side. So in this most common situation, typical situation, what will happen? There will be bilateral rib notching. Bilateral rib notching, because you can see the collaterals are arising from bilateral subclavian arteries or bilateral intercostal arteries and the internal thoracic arteries, and therefore there will be bilateral rib notching. Whereas in a situation, see here, where the coarctation is not at the post-ductal site or not post-distal to the subclavian artery but proximal to the subclavian artery, what will happen? The left subclavian artery is not getting good blood supply because it is distal to the coarctation, isn't it? So it will not give rise to collateral channels. So in this case, collaterals will arise only on the right. So there will be only right-sided rib notching. There will be only right-sided rib notching. In cases of coarctation, when the site of coarctation is proximal to the origin of the subclavian artery. Now, in case of a vascular anomaly, see here, the site of coarctation is normal, is the most common site, distal to the subclavian artery, just postductal, but there is a abnormal origin of the right subclavian. This is called aberrant right subclavian artery or ARSA. From where is the right subclavian artery arising? It is arising distal to the coarctation site. This is called ARSA or aberrant right subclavian artery. So which means that this right subclavian artery will not receive good blood supply. So because it is originating distal to coarctation, so it will give rise to collaterals only on left side. So there will be only left-sided rib notching. So there will be only left-sided rib notching. So these images will give you an idea, try to form a visual impression. Normally at postductal coarctation site, bilateral rib notching occurs. If coarctation is proximal to left subclavian artery, only right rib notching will occur. But if the coarctation is postductal but there is ARSA, that is aberrant right subclavian artery, it is only left-sided rib notching or collaterals that will occur. Yes. Now another classic feature of appearance, another classic appearance of the heart is what is called as a box-shaped heart. A box-shaped heart in Epstein's anomaly, right? So this is what gives rise to a typical box-shaped appearance of the heart. That is because the tricuspid valve is inserted more apically. So what happens? It is also dysplastic. A lot of reflux happens across the tricuspid valve. So most of the ventricular cavity is actually converted into a big atrial cavity. That is called atrialization of the right ventricle. And that is what gives rise to a shelved appearance or a horizontal or a vertical box-like configuration of the heart. And this is what gives rise to Epstein's anomaly, box-shaped heart. Right. Now, what is basically important for you for your exam levels as far as congenital heart diseases are concerned? Right, various cardiac appearances, are a clincher of a diagnosis. Along with these appearances, when you study the clinical presentation in pediatrics, right, that will lead to a more complete discussion, and that is something which will be completed in your pediatric videos. What we have achieved here basically is we have looked at the various classical imaging appearances. Right, let us quickly revise them. What appearances are seen? So Cor and Sabot appearance or boot-shaped heart is seen in what? So boot-shaped heart is seen in TOF, tetralogy of Fallot, right? Figure of 8 heart or snowman's heart, right? Figure of 8 heart or snowman's heart is basically seen in total anomalous pulmonary venous return, the supracardiac type, right? Gooseneck deformity is a slightly lesser known, appearance. This is a feature of endocardial cushion defect. Because in the endocardial cushion defect, the LVOT, that is left ventricular outflow tract, becomes excessively narrowed like this, right? It looks as if it is a gooseneck appearance. So this is what is the gooseneck appearance of endocardial cushion defects. Egg on a side appearance or egg on a string appearance is a feature of TGA, whereas a box-shaped heart we have seen is a finding which is seen in Epstein's anomaly. So these are few important various classic appearances of congenital heart disorders. Then we have discussed coarctation of aorta in detail. We have discussed what is the most common site of coarctation, postductal, distal to subclavian artery. We have discussed rib notching and why it occurs, which ribs are involved, bilaterally it occurs. Then we've also discussed special situations where only right-sided and left-sided right-sided and left-sided rib notching will occur. So see, young female with hypertension, coarctation is the cause of hypertension. Chest pain, cramping of legs because legs are not receiving good blood supply. Chest X-ray shows this figure of 3 appearance. If it creates an impression on the esophagus, it will create a reverse figure of 3 appearance. So the cause of hypertension in this particular patient is, yes, coarctation of aorta. We have also discussed what is this peculiar appearance of the heart, boot-shaped heart in tetralogy of Fallot. We have discussed why there is a boot-shaped appearance of the heart. We have discussed it is associated with a right-sided aortic arch as seen here. We have seen that the heel of the shoe is formed by the right ventricle, which is located over here, right? These are the various findings in top. It is the right ventricular hypertrophy which is going to elevate the apex, and that is what is going to create this particular appearance. Then we have seen, yes, a 12-year-old child presented with cyanosis, fatigue, right? Look at the classical appearance of the heart, right? This is the figure of 8 or snowman's heart, which is seen in supracardiac type of TA PVC, right?